I'm trying to put it in my mind. These are the cards the Lord dealt me, and these are the cards I have to play.
Some days I do better than others. You know, it's tough sometimes. I do the best I can. Some days I'm all right, some days I'm not okay.
Just because she has this illness doesn't mean that that's it. This is the end of the world.
Hello, I'm Kirsten Russell, and welcome to Activities of Daily Living, the first in a three-part series, A Time to Care. What you've just heard are some of the thoughts of home caregivers, each of them taking care of a loved one with Alzheimer's disease. Fortunately, we live in a time when medical research plays a significant role in our approaches to dealing with Alzheimer's disease and the effects that it has on our lives. Unfortunately, Alzheimer's is still a disease that affects our loved ones' memories, reasoning, judgments, and ability to perform even routine daily tasks such as eating and dressing. Over 4 million Americans have been diagnosed as being in some stage of Alzheimer's disease. Over 19 million Americans know of a family member or friend that has the disease, and over 70% of caregiving for those with the disease is done at home by people just like you. And the reality is that most caregivers are paying for the expenses associated with home care right out of their own pockets. Obviously, this is a very challenging and often frustrating time for you and your family. The good news is that there is help for you and your loved ones concerning many of the aspects of living with Alzheimer's disease, such as basic activities of daily living, making your home a safe place, and emotional and financial demands. We hope that you join us for this presentation, and you will feel encouraged about what will be invaluable practical approaches to you and your loved ones' daily routines. And very importantly, we hope that you will see that clearly you are not alone in meeting this unique challenge of this time in your life, a time that is truly a time to care.
The first thing people start seeing is short-term memory changes, some of which are normal, and sometimes it's difficult to start seeing when those changes start crossing the line into a dementia. Usually what happens is from the short-term memory you start seeing periods of disorientation, confusion, not recognizing things or people, less of the abstract thinking that we have and getting more into the concrete thinking, not being able to think of concepts as easily as one used to. Also, as the disease progresses, there may be changes in a person's personal hygiene or in how they're keeping their house. Those can be real dead giveaways when you know somebody who's been extremely meticulous about his or her appearance or house. Starting to withdraw a bit socially, maybe preferring just to withdraw and be alone or just not do anything. I've seen some clients who have said they've seen changes in their parents because they just want to sit all day. They have no interest in doing anything, and these might have been people who normally had very vibrant interests in life. One of the symptoms or behaviors that's exhibited by the loved one before a diagnosis is even made or presumed is that the person undergoes a change in his or her concern for their hygiene and for their grooming. The problems that seem to be with bathing, and we don't really quite understand still why, a fear of water can be a really big one, a real genuine fear. There seems to be some spatial and perceptual distortions, often associated with water. And I've seen in my practice carried to the extreme where I had one client who was deathly afraid of the sound of running water, either in the sink, in the tub, or in the toilet, which presented some very unique challenges to the family that we worked around. Also, there can be a real fear or an embarrassment factor because sometimes that person is just aware enough to feel very embarrassed and very ashamed that something isn't quite right and that people are reacting a bit to them. And again, a lack of awareness that even there's a problem, that there's body odors. They don't pick up on those odors. Other people will do it before they do. So what can you do about it as a family member? Create a safe and comfortable environment for yourself as well as for the person with the dementia. Here are some tips. First of all, you can adapt your bathroom in a very easy way and in a very practical way with a few items. For example, always have a shower chair. If the person seems to have poor sitting balance, get a shower chair with a back on it so the person is very comfortable. There are also shower chairs that are available in which part of the chair extends outside the tub. A handheld shower head is wonderful in that there's a lot of direction and versatility to be able to aim the water right on the part of the body that is being showered. Or sometimes even better, if the person with the dementia wants to use the shower head him or herself, less fear and probably better accomplishment of the task. If a person is actually sitting in the bathtub, be sure to keep the level of the water low, probably not more than a few inches. Water temperature is extremely important. The best thing to do is try to keep it as lukewarm as possible. Again, not too hot, not too cold. Even testing a little bit of the water on the inside of your wrist can really give a good sensitive indicator of the right temperature. And also noticing how your loved one responds with the water. Grab bars are a wonderful item, and those can be easily installed. Any contractor can do it. Very important to have the floor of the bathroom and of the shower or bathtub protected with some kind of skid protectors. Or a good bath mat will often do a good job too. Make sure your floor is dry at all times so that somebody's not going to fall, either you or your loved one. What's very important also is having a non-locking or even a keyed bathroom door so that your loved one can't end up going in the bathroom and then locking him or herself in the bathroom. Make sure the room is comfortable in terms of temperature. Probably your loved one is going to want it warmer than you do. First of all, they're obviously not going to have clothes on. And secondly, as we get older, our brain's temperature regulating mechanism is not as sensitive as it is when we're younger. So try to keep that in mind as well. Have plenty of towels available, assembled before you get started. You don't want to have to get a towel out of the hall closet and leave your loved one unattended. If the person is feeling still cold or excessively modest, you might put a towel over them, in their areas where they feel modesty, such as their genital area, below their waist for warmth. Or sometimes you can even get the job done if the person wears a bathing suit. You can manipulate around it, and again, if it makes your loved one feel more comfortable and happier and more cooperative with you, by all means go for it. The other thing is maintain a routine. Make it very predictable in terms of the time of day. Some people really thrive with having a bath or a shower at bedtime. It really calms them down and helps them sleep better. So see what seems to be best for them. You may base it on what their routine tended to be when they were more well. As we get older, our skin gets drier, and we really don't need a full bath necessarily every day. So try to establish a routine where maybe you might give a person a full bath or shower twice or 3 times a week. A lot of it's going to depend if they have trouble with maintaining control of their urine or their bowels. That can often drive your bathing system. Sometimes if you're not using a full bath or a full shower, just really a sponge bath with face, hands, definitely hands, as you never know where people's hands have been, much less somebody who is confused. And even just their genital area to keep their skin clean and to reduce any odors. The most important thing is never, never, never leave that person alone. By all means, be very calm as a caregiver and move slowly, deliberately, and again in a very predictable one-step-at-a-time manner when you bathe. And often when there's a very good routine, people are much more cooperative. Keep the hair clean and short. Don't worry about having somebody with long hair that you're trying to keep very, very coiffed well. It's a lot of hassle, And the best thing to do is, again, get a nice, short, clean, becoming haircut. Have a visit to a beauty salon or a barber shop. That can be the most wonderful thing. Often a person with dementia loves to have the attention. What you might have to be prepared for, though, is that you will have to stay during that appointment, because often it's very difficult for people with dementias to sit still and cooperate for that period of time, whether it's having the haircut or if a woman is under the dryer, that can be difficult too. So it's very important that you're there. It'll help the person, it'll help the stylist tremendously. Products, I think a very mild shampoo, like a baby shampoo, is really a nice thing to use. There are also products that are available that maybe you've had experience with in hospitals. There's called like shampoo in a cap, or no-rinse shampoos are easily accessible in the market too, to use between full shampoos. But again, if you keep the hair short, it's easy to rinse when a person's in the shower, especially using that handheld shower. Grooming also includes judicious care of toenails and fingernails. Keep them short and keep them clean. It prevents bacteria from getting under the nails and infections being passed on through the nails getting dirty. If your loved one has known decreased circulation in the legs or diabetes or both, it is very important to have regular care by a podiatrist, a foot doctor, in taking care of cutting and otherwise maintaining people's feet.
The most important thing about caring for an individual who either has poor circulation or diabetes is monitoring, vigilance. Assuming that you have a podiatrist, you may go once a month, once every 2 months, or even 3 or 4 times a year. The fact is that a person can ulcerate significantly within hours. Therefore, it's important, if you're caring for someone who's homebound, if you're caring for someone who is bedridden, that you have a timetable in which you assess their skin. Are there breaks in the skin? Are there areas of redness, sores that the person may not be able to cognitively speak about? Are there areas that appear to be unhealthy to the caregiver? These are things that need to be identified, and appropriate referral needs to be made at that moment. Obviously, footwear is important. Our culture has an unfortunate tendency to buy and wear shoes that are too small. I will recommend a person take a tracing of the foot in question, cut that tracing out, and shop for shoes attempting to fit that tracing into the shoe that you're intending to buy. There should be a reasonable fit there. And two, I want to mention that there's evidence that the thicker the outsole of the shoe, in other words, the thicker the cushioning layer of the shoe is, the more this may actually encourage this person to fall or trip. Given the consequences of that, broken hip and so forth, this is something to be avoided. Fortunately, there are dozens of shoe companies which make shoes specifically for the geriatric market. They make shoes specifically for the diabetic and vascularly impaired market, and these shoes are designed to either fit deformity, hammer toes and bunions in particular, or to stretch. So if there's any question about footwear, either your shoe store has the answer, or you can get appropriate professional referral through your primary care physician or podiatrist.
Some tips on shaving. First of all, you want to have your area very well lit, a very obvious suggestion perhaps. Generally, in terms of razors, my preference that I give people is usually an electric razor. But again, if that person is afraid of the razor sound, then you use a safety razor. You can often use razors that are designed for sensitive skin. You don't need the triple action one that you see in the commercials with the sports figures. Instead, often a razor that's marketed for women tends to be one that will be very gentle, but again, get the job done. You might want to try shaving your loved one, usually a man, in front of the TV. If the person enjoys watching TV or just focuses very calmly with the TV on, it can provide a distraction and help you safely get the shaving done. Mirrors are a controversial area sometimes. Sometimes a person with a dementia gets a very distorted view of how they look in a mirror and could become very frightened. You might not want to have a mirror in front of them. People who have these dementias and cognitive problems often do not eat properly. First of all, we sometimes find our elders are starting not to eat particularly properly as they get older anyway, and the problem is compounded more with people with dementia. Their choices and their amounts of food can change dramatically, so that they may either eat so much that they don't have that internal signal in their brain telling them it's time to stop eating, or it can be the other extreme where they are just not eating and drinking as they should. And good nutrition and adequate fluids are really important.
There's actually two different types of Alzheimer's, persons with Alzheimer's, and those are people that walk a lot and people that become immobile. So we're going to talk about both of the sides of the coin. Pacers and wanderers. These are people who tend to walk around a lot and they use up a lot of energy, and so they will tend to lose weight over time. For those people, you may need to add calories to their diet. So you might want to add something like yogurt or some milk products or dairy products and try to get them to add some calories, not necessarily fat, because we still want to avoid fat for all older people. But so we want to enhance and fortify shakes, for example. Adding ice cream is a good way to fortify someone's diet. If they tend to walk around a lot, they can walk around with an ice cream cone. Immobility, the other side of the coin, that's going to cause limitations in terms of metabolism. It's going to slow their metabolism, and so what we want to do to compensate for that is to, one, increase the protein in their diet, and two, increase the fluid intake. Additionally, increase fiber. Okay, so all of those things are going to help that person to, at least with their diet, they're going to be able to compensate for that immobility. People with Alzheimer's, this is one of the early typical signs, is that they do lose their sense of smell, or their sense of smell is diminished. And sense of smell plays an important role in eating because it kind of works together with taste. When you have a cup of coffee, you smell the coffee, and then you taste the coffee. And certain things happen to anticipate that food coming into your mouth. So one of those things is salivation. Now, salivation is going to be diminished because of the decrease in sense of smell. And so you're going to need to pay attention, if you're a caregiver, to how moist foods are. You want to avoid dry foods that are going to need a lot of salivation in order to be able to swallow them. You might want to look at alternating dry with more moist, such as serving applesauce with pork chops, and alternating bites of pork and applesauce, and that will compensate for that decreased salivation.
Dry mouth is the inability to produce saliva. The person may complain that they have a dry mouth, it's difficult to eat food, they have to sip liquids all the time, but many older people with dementia may not be able to express that problem. They might not even know they're suffering from a dry mouth. So the caregiver needs to be looking for the signs of a dry mouth. The patient may have very dry and cracked lips. They may notice in the mouth that the tissues of the mouth are very dry and that food is sticking to the surfaces. They might notice that the person is having a great amount of difficulty swallowing their food. They might chew their food repetitively and the food just stays in the mouth because they're not making enough saliva, and the saliva is needed to wash that food into the throat. So if the caregiver actually hears the complaint of a dry mouth, or they believe that the person is suffering from a dry mouth, they need to think about what is the underlying reason for the dry mouth. And a major reason are many medications that patients are taking. Many medications they're taking have side effects, and those side effects include a dry mouth. If that is what is the cause of the dry mouth, then caregivers need to speak to their physicians about the medications that their patient or their loved one is using, and maybe some medications can be switched, or maybe they can be substituted for medications that have fewer side effects.
There's a great deal that a caregiver can do to try to enhance the eating experience for someone with Alzheimer's. In the beginning stages, when you first notice that things are happening, the person is having problems with cognition and memory loss, the first thing that you're going to probably notice is the distractibility and the lack of attention. And in that case, you're going to be doing a lot of redirecting to the eating experience. The caregiver can do that with tactile cues and also with visual cues. So we're looking at possibly repositioning food, for example, which is a visual cue. Handing somebody the cup, okay, and putting it in their hand. So any of those things are going to redirect. Usually reminding them auditorily doesn't work as well. As the person becomes more involved, they're going to have less attention span. And the other thing that's going to happen is they're going to lose their ability to understand a sequence. So normally there's a sequence to a meal, okay? We start with an appetizer sometimes, or at least we have a main course, and we might have a salad, and we might have a drink, and we might have a dessert. So there's kind of a progression that occurs. People with Alzheimer's lose that ability to understand the progression. So they're going to start with dessert because that's what they like, or maybe that's the easiest to eat. So as the person becomes more involved, you might need to actually give them one thing at a time and not give them their whole meal at the same time. So you want to start out with what you want them to eat that's most important, maybe the meat, maybe the protein, which is something that they really need. And obviously the dessert is going to be last, so that'll be more like a reward.
Try to keep mealtime very simple. As people get older, they find they get full more easily and that big meals are physically uncomfortable. Again, also, the judgment being impaired, they may tend to overeat because they don't have that signal that they need to stop eating. Limit the number of foods that are being served to the person, whereas the person might have enjoyed a full array of foods at one time. It can be very confusing and often create non-cooperation. Smaller portions are often the order of the day. You may need to cut food into small pieces, or even puree if you find that people are having difficulty swallowing. Finger foods are always a great choice. It gives the person the independence and the enjoyment of eating when they can feed themselves. There are weighted plates and cups that cut down on spills. There are also straws that can be helpful with ingesting liquids. Have meals in a normal or familiar place and with familiar sounds around them so that, again, more routine being observed there. And finally, don't worry about messes. If you want, put some plastic underneath the chair where your loved one is sitting. They're bound to make some messes, but if they're able to feed themselves and they're happy and they're feeling independent, don't you think that's worth it? It's very important to keep up good dental hygiene because you obviously want to avoid infection. Also, results of infection can create pain in the mouth and gums, a poor diet, and no motivation to eat. And people with dementia sometimes either have very, very voracious, enthusiastic appetites or tend to cut down on what they'll eat. So again, keep those teeth nice and clean.
I am frequently asked by caregivers what kind of behavioral cues should they be looking for if their loved one or if their patient has an oral health problem. And this is a difficult question to answer. because many older persons can't complain of an infection or a sore or a dry mouth? I believe the answer is knowing the patient or the loved one very well and looking for slight behavioral changes. For example, is that person no longer interested in eating or in drinking? Do they not want to sit with the family and have a meal? Do they start having different behavioral cues in terms of washing their face or washing their body, or other slight cues that the person is not feeling well? Personality changes, someone who is more excitable, or someone who is more impatient. Slight changes in personality or behavior that might clue them in that something is wrong. Hopefully the caregiver is sensitive enough to even look in the mouth or consider the mouth as a source of pain or infection. A very easy thing for the caregiver to do is to simply look at the teeth and in the gums. If there's a lot of plaque on the teeth, if the gums look red, if there is spontaneous bleeding, which means you just retract the lips and you see bleeding coming from the gums, then you have a good sense that that patient has gingivitis. If you see dark spots on the teeth, that probably indicates that they have an early form of cavity. So a simple cursory examination of the mouth and the teeth by the caregiver could really give them a clue on if they have dental problems and if they're adequately taking care of their teeth and gums. If, in the opinion of the caregiver, there is a lot of plaque, food debris, black spots on the teeth, then the caregiver should step in and assist in doing some toothbrushing. A good way to do that is by standing next to the patient, holding the patient's head, talking to the patient so that they know who is providing the care, and trying to gently take a toothbrush, go into the sides of the cheeks, and at least start brushing the outer portion of the teeth. Under no circumstances should you put your fingers in someone's mouth, because there's always the risk that the patient might get upset and they might bite down on your finger, and they could actually hurt you. So if you're going to put your fingers near someone's mouth and someone's face, keep it on the outside of their teeth. And by talking to the patient, reassuring them, doing this in a place that they are familiar with, hopefully the caregiver can do an adequate job of brushing that person's teeth. The typical toothbrush that is designed for adults has a very small handle. And it has a small handle because most people have adequate hand-eye coordination to use that toothbrush. If it's felt that the older person has lost some of their hand-eye coordination, motor coordination, then there are toothbrushes on the market that have larger handles, and it's easier for that person to grip the toothbrush. And I recommend that caregivers get those types of toothbrushes. I think one issue is talking to the patient about seeing the dentist. Another issue is getting the patient early on in the disease process to a dentist who is familiar with the disease and is going to be a trusted partner in the care of that patient for this prolonged illness. Another thing the caregiver can do is come into the dental office with the patient. Sit with the patient, hold the patient's hand while the dentist is doing an examination. The caregiver can instruct the dental hygienist and the dentist on what kind of special techniques they have to calm the patient down. Is it stroking the person's head? Is it using the person's name repeatedly? Is it touching them on the shoulders? Sometimes the time of day can help. Patients might be less agitated in the early morning, maybe more agitated in the afternoon. So these are cues that the caregiver can give the dentist and can help the patient deal with the fear of seeing the dentist. Patients with dentures need to see a dentist at least on a yearly basis to look for the fit of the denture. There's a second reason why people without any teeth and wearing dentures should see a dentist at least on a yearly basis, and that's because that as you get older, you become more likely to develop oral cancer. And the dentist can take x-rays and do a head and neck and mouth examination to see if you have any signs or symptoms of oral cancer. Oral cancer is a disease that can be readily cured in its early stages, but in its late stages, it is a killer. So as patients get more and more demented, they need to see the dentist even more frequently to provide cleanings and intercede early in order to prevent other significant problems from occurring later on in the disease process.
You might have noticed before you even had a diagnosis of dementia that your loved one was starting to dress inappropriately, perhaps wearing clothes that were inappropriate for the weather, inappropriate color combinations or choices of garments, or even layering things such as a sweater over a sweater, or slacks over slacks, or a dress over a dress. That can happen. So you can say, well, what do I do? It seems as if dressing is something that would come so naturally to any adult, but with somebody with dementia, it could become very baffling. But here's what you can do. You may find that they just need some verbal instruction, or you might find you actually have to physically help them. You also might have to persuade them to change their clothes, because we've talked before about how bathing and grooming can be an issue. Willingness to change clothes can sometimes be in that category too. Here are some ideas. Use clothing that is easy to get on and off. Loose slip-over tops, slacks that have elastic waistbands. Get rid of the clothes with the buttons and the fasteners if you possibly can. Also with shoes, there can be Velcro or slip-on shoes that can be helpful. Getting items in a certain color or a certain style and buying multiples of those can be helpful, particularly if you know your loved one enjoys a certain style of clothing. For example, if your mother has always worn slacks, you're not going to start putting her in dresses now, probably. Help them be consistent and familiar with their clothing as much as possible, and you'll have better success. Lay out clothing in terms of the order in which they're going to put them on. That can help with verbal or even physical cueing of your loved one. Give very brief, clear instructions if you have to instruct them. Don't give them a whole string of commands about what to do, as much as you might just simply say, now it's time to put on your top, Mom. Do remain patient when sometimes they either are uncooperative or not doing it so-called right. If they put something on backwards, don't worry about it. Sometimes you can't even tell the difference with a top, but if it really looks strange where you think the person could be embarrassed, then by all means, help them gently adjust it. Sometimes even making light of it, saying, oh, you know, sometimes I do that myself, Mom. And sometimes we do if we don't have tags to remind us. Make sure when you're doing the dressing that the room is either warm enough or cool enough so that they're comfortable. Also, once again, establish a routine in terms of where the dressing is going on and about what time of day you schedule the dressing. Keep the wardrobe simple, as we mentioned before. Get rid of the clothes that are not worn or really probably are not appropriate at this point. You might even have pictures on dresser drawers of what's in the drawers. You might have a photograph of socks, for example, in the sock drawer. That might help cue your loved one to be able to find those things for him or herself. Now you can get into the undressing as an issue potentially. Sometimes your loved one, just like with bathing, can put up resistance due to either confusion about what's expected or embarrassment, which ends up with frank resistance. Give your loved one an option to sleep in the clothes they've worn during the day. If they're wearing comfortable clothes, it's not an issue that they have to get in a nightgown or have to get in pajamas. The important thing is help that person maintain as much dignity and independence and participation in dressing. It's best for them and it's best for you. An issue that can sometimes be very problematic and very frustrating can be the issue of incontinence, or when your loved one has the inability to consistently control their bladder or their bowels. It can be one or both. It can be all the time or sometimes. It can be seen at certain times of the day or night more frequently than other times. You often see patterns as time goes on. There are many causes for incontinency. Here are some things to consider with your loved one's doctor. A urinary tract infection may be causing the problem. Symptoms that you'll see with your loved one is going to the bathroom very frequently, or they might have blood in their urine, or they might complain that it hurts when they go to the bathroom and try to avoid going to the toilet. They may have pain at about the waist level, which would indicate they have a kidney infection. So if it's tender there, that's something to consider also. The other thing is, don't look necessarily for a fever to be a symptom. Usually with older people, they don't necessarily have temperatures or fevers when they have urinary infections. Certain medications affect bowels and bladder. Discuss that with the doctor. Acute illnesses can sometimes create temporary problems with lack of control of bowels and bladder. Diabetes that's untreated, or if the person's blood sugar is elevated, can create problems with urinary control. Heart disease can sometimes create problems as well. Women particularly can end up with problems with weak muscles in their pelvis, often from childbirth or from vaginal or rectal surgeries. There may be prostate problems with men. Another cause of incontinency can be dehydration, not getting enough fluids. Again, unless there's heart problems and the doctor indicates otherwise, make sure you're getting between 1 quart and 2 quarts of fluid into your loved one in a 24-hour period. As we said before, very, very great emotional challenges to incontinence. It's frustrating, it's messy, it can be embarrassing, and it can create a lot of hostility with caregivers when mom or dad can't seem to get to the toilet in time. Like with everything else, with behaviors that you find difficult, remain calm, remain accepting of your loved one, where they are and what they do. Some indications you might have that your loved one needs to be toileted is watch for pacing or restlessness or attempts to take their clothes off. Those are cues you need to get the person to the bathroom. Often a very effective mechanism with improving control of the urine and bladder function is gentle reminders and just automatically bringing your loved one to the bathroom, usually every 2 or 3 hours during the day, making sure that they don't drink as much fluid after dinner, and making sure that they're toileted when it's time to go to bed at night. Sometimes a sign indicating the bathroom door is a place that will cue the person as to where the bathroom is, because they might get confused because all the doors in the house look alike. Some other household aids with incontinency: plastic sheets on the bed protect mattresses, and there's actually plastic mattress covers that are well ventilated, but again protect the mattresses. There are bedwetting alarms that can be placed on the bed that can help to cue the person it's time to get up and go to the bathroom. Also, having ceiling fans to ventilate your rooms well, and having plastic or some kind of block under a rug to keep floors protected can be helpful. When you're taking your loved one out, always scope out where the closest restrooms are. If you're in a shopping center, if you're in a restaurant, if you do that, that can really help when they need to go, that you can quickly respond because you know where to bring them. Having simple and easy to remove garments are helpful. Again, elasticized waistbands on pants are probably the greatest thing that can help them and help you. There are many kinds of adult undergarments on the market. There are full diapers, disposable diapers that can be used. There are reusable diapers, or rather washable diapers that can be used in plastic pants that can be used. Sometimes just a liner inside underwear can do it, and there are various sizes and thicknesses of panty liners that can be used. If your loved one does have an accident, please don't scold them. They didn't want to have an accident. Again, just be very calm and very unassuming, and just simply help them get cleaned up.
Once again, we want to thank you for joining us for A Time to Care's Activities of Daily Living. Obviously, your situation at home presents its own unique challenges depending on the stage of your loved one's disease, his or her personality, and the resources you have available to you. We're happy to have been able to share with you some of our insights into living every day with Alzheimer's disease, and hope that you will take with you any approaches or techniques that will be useful to you. We hope that you will join us for additional videos in our series, A Time to Care. And finally, we hope that as a caregiver, you will find the encouragement that you need.